first. Okay, thank you. You can start now.
Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today. Before giving the floor to our dear guest, I want to introduce our team. I will be the moderator of today's conference. My name is Efecan Erişken. I am the one of the residents of the neurosurgery department of İzmir Atatürk Training and Research Hospital.
Sorry, Efecan, can you speak a little bit louder?
Okay. These online education meetings have started with Associate Professor Hasan Kamil Sucu, the program manager of the neurosurgery department of our hospital, and goes on with the contributions of all residents, also with the contributions of the neurosurgeons who graduated from our hospital. I can kindly ask you to keep your microphones turned off during the presentation of lecturer to avoid voice and noise pollution. You can ask your question not by opening your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussions isn't appropriate for the format of our meetings. Please do not ask for your microphone to be turned on. And I would like to introduce our guest. It's my privilege to present our lecturer, Professor Gabriel Zada. Gabriel Zada graduated from University of California, San Francisco School of Medicine in 2004. Completed his residency in neurosurgical surgery in University of California Medical Center in 2010. He was assistant professor of neurosurgery in Keck School of Medicine, University of California in 2016. Between 2011 and 2016, he became associate professor of neurosurgery, otolaryngology, and internal medicine in Keck School of Medicine of University of California in 2016. He has been a professor of neurosurgery, otolaryngology, and internal medicine in Keck School of Medicine since 2020. Professor Zada has been director of University of California endoscopic skull-based surgery program since 2011, co-director of University of California pituitary program since 2013, and co-director of the University of California radiosurgery program since 2015. He got American Board of Neurological Surgeons in 2015, and he has numerous awards. He is manuscript viewer of many prestigious journals like Neurosurgical Focus, BMC Cancer, World Neurosurgery, Neurosurgery Journal of Neurosurgery, Journal of Neuro-Oncology, Journal of Clinical Neuroscience. This means that if you want to publish in neurosurgery article in prestigious journal, there's a high probability that Professor Zada will review it. He is associate editor of Operative Neurosurgery, Journal of Neuro-Oncology, section of Frontiers in Oncology, BMC, Endocrine Disorders. He has 421 articles, and his age index is 44. His stations is 6,050. And now I would like to introduce and I would like to give him to speech. Welcome, Professor Zada. Now you can start sharing your screen, sir.
Thank you so much. Thank you for the excellent introduction. I'm very honored. Is it possible for the host to allow me to share my screen, please?
Hocam, please.
Yes.
I would like to thank Professor Suçu and the entire İzmir neuroscience program. Thank you all for having me. I'm very honored to be able to spend some time with you all this morning.
Thank you.
It still is not allowing.
Atacan, will you give permission to screen sharing? Is it okay?
It's okay.
Okay.
Working now? Okay, let's try it. Yes, very good. Okay, thank you all for the opportunity to speak this morning about cystic lesions of the sellar region. We're going to talk about a variety of them. It's not a topic we really talk about that often. We can talk about pituitary tumors or craniopharyngiomas, but to address them all as cystic lesions and what the differences and commonalities are is what I hope to address today. So again, thank you so much for having me today. It's nice to spend time with you across the world here. When you see a cystic mass in the sella or suprasellar, parasellar region, you should maintain a broad differential diagnosis. The most common is, of course, Rathke Cleft Cyst, which has a very high prevalence, over around 20%, depending if you look at autopsy studies or MRI. And cystic pituitary adenomas are also fairly common because pituitary tumors are so common. Of course, there's craniopharyngiomas, and then you get into less common lesions, arachnoid cysts of the sella, rare, but can be symptomatic. Encephalocele, mucocele, not really cystic, but can be fluid-filled. Infectious lesions occasionally can arise in the sella and have a cyst. And then inflammatory lesions such as xanthogranuloma. And finally, other epithelial lesions such as epidermoid and dermoid. So we're going to be addressing some of these today and their management. So here are some examples of cystic lesions. The one on the left is a Rathke's cleft cyst. The one in the middle is an arachnoid cyst. And the one on the right is a cystic non-functioning pituitary adenoma. They can look very similar, but the clinical presentation and the management and outcomes can be different. And it's very important to be able to try to identify these and have a plan going in before surgery. So we'll try to talk about some of those today. The other thing I hope to relate to all of you is that there is a spectrum, especially of epithelial lesions and developmental lesions that go from very benign Rathke's cleft cysts, which are pure cysts, all the way up to neoplastic, aggressive lesions, such as recurrent craniopharyngiomas. And it's thought that maybe there's a spectrum of disorders that are are related in some way and can even progress from one to the other. And that has been shown in many articles about progression from simple Rathke's cleft cysts to aggressive craniopharyngiomas. So we should keep this in mind as we move forward, that they may have an underlying common ancestor. The benign Rathke's cleft cysts go from a single layer of epithelium, and as they become more aggressive, we call them more atypical Rathke's. They develop several layers of cuboidal epithelium, and they start to mimic what a craniopharyngioma looks like. This is a more simple papillary craniopharyngioma, also with cuboidal epithelium. And the adamantinomatous ones we know are different. They have more keratin and more calcium in them. So let's talk a little about Rathke's cleft cysts. As we know, they're pretty benign, but they're known because they can be recurrent. And so they're often found as an incidental finding, but we know they can be symptomatic. When patients have symptoms, it's very common for them to have headache. And that's one of the things I look for before I recommend surgery for patients with Rathke's cleft cyst is headaches. And the headaches can often be occipital in nature and radiate to the occipital area and be associated with photophobia as well. Endocrinopathy can occur, especially elevated prolactin levels from pituitary stalk effect. And diabetes insipidus can be more common because these cysts arise in the area of the pars intermedia between the anterior and posterior pituitary gland. So especially after management, it's very common to see transient diabetes insipidus. Vision loss can, of course, occur as well. The goal when you're treating a Rathke's cleft cyst is usually not resection. It's usually fenestration at first and marsupialization. So to open the cyst widely, to drain it, to remove the cyst contents, and to try to maintain its patency is very important. We do not recommend complete resection of a cyst on the first treatment because of the associated risks of hypopituitarism, diabetes insipidus, and CSF leaks, as well as other complications. So for first-time treatment, recommended treatment is fenestration and drainage. However, they have, despite that, up to a 20% recurrence rate over 10 years. So we're going to talk about that a little as well. It's also important to ask the question, why do people develop these cysts? And of course, we think they're remnants of Rathke's pouch from development, but there seems to be also possibly a common ancestor of midline cyst development. So we published this article this year with some of my colleagues in Vienna, looking at a multi-center series. And we found that in patients with Rathke's cleft cysts, the prevalence of pineal cysts was much higher, almost 3 times as high as normal, the normal incidence in patients. We don't know why this is. We don't know if there's an underlying ancestor or genetic or developmental reason, but it would make sense that midline cyst formation may be a result of some sort of developmental issue. So typical Rathke's cleft cysts, they look very simple on MRI. They're often located in the sella, usually midline in the pars intermedia. You can often see the anterior and posterior gland splayed around the cyst. Or they can be a combined suprasellar, intrasellar cyst, or even a purely suprasellar cyst. And these can all be different variations of Rathke's cleft cysts that we consider typical. Here's some other examples. They can have varying patterns of T1 and T2 intensity, which can suggest the different contents, which can go from pure fluid up to highly proteinaceous or even calcified contents. And so again, it's very important to understand the pathology and that these can be all on a spectrum. So the very simple cysts have a single layer of epithelium, and this can become much more complex as we move forward. So the cysts that tend to recur have a thicker capsule, as you can see here, not only on MRI where there's more contrast enhancement of these cysts. So these are recurrent, atypical, more aggressive Rathke's cleft cysts, often associated with hypopituitarism. And when you look on pathology, you find multi-layer columnar epithelium. And the key word on pathology is squamous metaplasia. That is one risk factor when you see squamous metaplasia for recurrence. Even kids can have Rathke's cleft cysts. This was a series we published in children. And when you see these, they often present with headaches and they often have hypopituitarism in kids. So let's talk about the management a little. Of course, here's the sella. There's a lot of ways to treat these. This was an older video, but what's important to remember, when you open the dura on a Rathke's cleft cyst, the next structure that you will find is not a tumor, like when you do a pituitary tumor surgery, but it's the normal gland. And you have to be careful when opening the dura because next you will incise the gland to drain the cyst. And When we do Rathke's cleft surgery, we focus on aiming very low, staying very low in the sella, because as soon as you open the cyst, the cyst will collapse and the arachnoid can come down. And that's where you can get a CSF leak. So here's an example of a more proteinaceous cyst. And some of these are older videos, but you can see a calcified, almost stone in this Rathke's cleft cyst. And once you're done draining it, you want to assess for a CSF leak. If there's no CSF leak, we want to get rid of the dead space. And that's something that we like to do. We think dead space is the enemy. So some gentle packing is usually okay. And here's a more recent one that we've done. This was a 61-year-old woman with headaches. And in an older patient, new headaches suggest that something is going on. Here's the sella. We're doing a wide sellar decompression, using a Doppler on every case, opening the dura low, and then making an incision very low in the sella, in the normal gland, until we drain the cyst. So these are not technically challenging, but it's important to use good technique. Some people like to do wide marsupialization with the sphenoid mucosa, which is also a nice technique to use. We just like to widely marsupialize this and then try to avoid a CSF leak at all costs. It is nice to take a biopsy of the wall. And when I do that, I do it from the floor because we want to have pathology confirmation. You don't want to take a biopsy from anywhere near the arachnoid or diaphragma sella. And then I usually do some gentle packing with gel foam, which tends to get reabsorbed in the next couple weeks, and wide marsupialization. And this usually results in a very low incidence of new hypopituitarism. And most patients do very well. So here are some of our results over 2 decades of management in patients with cysts. Now, in this series, we reported risk factors for recurrence of Rathke's cleft cysts. And when we looked at that, squamous metaplasia was the #1 risk factor for recurrence. The second risk factor was having to repair a CSF leak. So if you have to put a fat graft in, or fascia lata, or a pedicled flap, those are associated with recurrence of the cyst, because you are closing off the cyst wall. And that is a major risk factor for recurrence. So whenever we have to do a CSF leak repair, or I see a thickened wall with squamous metaplasia, or it's already a reoperation, I have a high likelihood that this patient may recur in the future. When we're doing reoperation for Rathke's cleft cysts, especially on a 3rd time operation, we will be much more aggressive and consider full resection of the whole cyst wall. Even if there is new hypopituitarism, we start to treat these more like a craniopharyngioma after they've recurred on the third time. In terms of management like craniopharyngioma, I've had to give radiation to one patient with a very aggressive recurrent Rathke's cleft cyst, and it completely disappeared and was controlled. And there are some reports of radiation for aggressive Rathke's cleft cysts with excellent results when the radiation is fractionated, and a couple reports of radiosurgery as well. Okay, let's change gears here from Rathke's cleft cyst. This is a different lesion, and you'll see that the pattern of this is a little bit different. You don't have the location in the pars intermedia. These are arachnoid cysts of the sella. Very rare lesions, but you have to be mindful of them. We don't like to operate on arachnoid cysts, as you know, as neurosurgeons, whether it's a middle fossa arachnoid cyst, they have to have a very good reason for surgery. And when patients have a growing cyst or vision loss, or extreme headaches, those are the reasons. So occasionally we'll treat patients with arachnoid cysts when they look like this. You have to be mindful that the risk of intraoperative CSF leak rates is very high. And some of these patients have underlying hydrocephalus or elevated ICPs. And so sometimes the best approach may not be endonasal. On pathology, you'll find a simple arachnoid cyst membrane for these, which is pretty classic. And here's an older video of an endonasal case for an arachnoid cyst. Again, simple fenestration, no aggressive resection, and trying to avoid a CSF leak. What's different here versus management with other arachnoid cysts is you do not want to fenestrate these into the distal cisterns because of the risk of a high flow CSF leak. So simple fenestration from below, trying to avoid a CSF leak is a good approach. Here's another case of an arachnoid cyst. And with this one, we wanted to avoid an endonasal procedure and repair. And the patient did not want a big endonasal case. So we did an eyebrow craniotomy with a keyhole eyebrow supraorbital flap. This was about a 1-hour operation, and patient went home on post-op day 1, fully endoscopic case. So no need for CSF leak repair. And I think this is also a viable approach. But in this case, you don't need to do any fat grafting or repair. So here's the endoscope, of course, right optic nerve, left optic nerve, tuberculum sella, and simple fenestration here. This was an older patient. All we do is drain the cyst, widely fenestrate it, take a biopsy, avoid the optic nerves, of course, leave the arachnoid on the optic nerves. And here's a biopsy, and we're done. And this is a 1-hour surgery. Patient can go home post-op day 1 or 2. And post-op imaging shows a decompressed cyst. He's now 5 years out with no recurrence, and the cyst remains this size. And here's the optic nerves now decompressed, and vision improved post-op day 1. So here's another example. Looking again, these look like cystic lesions, but when you look more closely, you can see a little bit of some differences here. You see some thickening here around the wall. And this one does not look like a midline cyst. It looks eccentric to the right side. And of course, this is most likely the normal pituitary gland. So these are cystic adenomas, which you'll find as well. And you want to be mindful of these and have a plan. We grade all of our pituitary adenomas in terms of consistency, going from number 1, a pure cyst, up to number 5, a calcified tumor. And so we, although it's only about 5% of adenomas that are pure cystic, we do see them. So you want to be mindful of them. And this is a pure cystic adenoma. You will find some tumor, though, around the edges. And so it's important to scrape and make sure you send pathology so that it's not confused with a Rathke's cleft cyst. And then these go all the way up to soft adenomas and then more firm adenomas in our grading system. Number 1 is a pure cystic adenoma. Be mindful that you can find other epithelial lesions in the sella, including epidermoid cysts and dermoid cysts. And these are, of course, are usually characterized by, they can have calcifications, but of course, diffusion restriction is the hallmark of this on DWI imaging. And that's how you can differentiate these from arachnoid cysts on a preoperative imaging. So we've seen a variety of suprasellar, parasellar, epidermoid, and dermoid lesions. Here are some examples of dermoid lesions, which tend to be more on the midline vis-a-vis epidermoid lesions, which are often more paramedian. So here's an example of a gentleman who presented with a cranial nerve palsy on the left. He had a cranial nerve 3 palsy and diffusion restriction. So this is a more lateral transpterygoid approach the cavernous sinus and petrous apex region for an epidermoid. And with this, again, you don't want to resect the whole capsule. You want to remove the keratin contents. And this one went all the way back to Meckel's cave and the posterior fossa. And so we were able to decompress this, but we did have a CSF leak we had to repair with some grafting. But of course, this went all the way back to Meckel's cave, and his cranial nerve palsy improved a few weeks later. There's the CSF communication to the posterior fossa. So although we had to repair this, the patient did it very well. We did a multi-layer repair with a flap, and he did great. And here's the flap over it. And postoperative imaging showed improvement. Okay, let's change gears one more time and talk about the biggest offender in this area, which are craniopharyngiomas, of course. And as we know, these tend to arise from squamous cell rests, often located on the pituitary stalk, although they can arise in the gland or rarely in the third ventricle primarily. And of course, there are many grading systems for craniopharyngioma location. They tend to be retrochiasmatic and originate from the stalk, and that's a big tip-off for their management. Patients, although there's a bimodal distribution and reported based on age, we see these in all ages: kids, adults, younger adults, and they can all have vision loss, headaches, of course, hypopituitarism, DI. The children tend to get, of course, developmental deficits. And the classic presentation is a short stature, hypothalamic obesity in a child, occasionally with hydrocephalus. Whereas adults tend to get hyperprolactinemia, hypopituitarism, vision loss. And older adults tend to present with altered mental status and memory loss, as well as lethargy. So classic, typical craniopharyngiomas, of course, it depends if they're adamantinomatous or papillary, often will be located primarily in the suprasellar region, of course. And the adamantinomatous ones are classically cystic and solid, and of course can have calcifications in them. And of course, we know they can be retrocellar, paracellar, supracellar, and grow in a variety of directions. The first surgery for a craniopharyngioma is the most important surgery. It is the opportunity to remove all of the tumor and have a definitive outcome. But of course, maximal safe tumor resection is really the key. There have been some very important studies, especially by my colleague Ted Schwartz, who have reported that it's beneficial to remove the whole tumor, even if you need to remove the pituitary gland and stalk, because even trying to preserve the stalk and leaving some residual craniopharyngioma not only results in tumor recurrence, but it's often very difficult to achieve a hormonal preservation, even when you're trying to preserve the pituitary stalk. So we're very aggressive in trying to remove the whole tumor with the first surgery for craniopharyngioma. Of course, the papillary ones tend to have these multi-layer columnar epithelium, and the adamantinomatous ones have more keratin and calcifications. And these can be very nasty tumors, of course. On CT, this is the hallmark of the adamantinomatous variety, is the cystic and calcified subtype. And so you can separate the adamantinomatous from papillary from Rathke's cleft cysts using a variety of imaging and pathological findings, but they can mimic each other. So you can see that some of these can start to look like Rathke's cleft cysts, but these are craniopharyngiomas on pathology, and they don't have to be purely suprasellar. So there can be a spectrum there. With regard to management, there's a lot of management options. Sometimes the best thing is observation. Radical resection is preferred. Sometimes the right answer is subtotal resection, especially in much older patients. Occasionally, stereotactic aspiration or shunting can be used, but we try to avoid this. We don't like putting foreign bodies into the cyst because of the adhesions and inflammatory reactions. We do use radiotherapy, often fractionated if there's residual. And then some people have tried a variety of radioisotopes or bleomycin, but we try to avoid these at all costs. So in terms of approaches, there's also a variety, and we can talk about that. There is a role for craniotomy, especially in reoperation, but of course the endonasal extended approach has become the mainstay for craniopharyngioma, and it's definitely the go-to for a majority of these. But when you're considering this, you want to look at the relationship to the optic chiasm, especially if you have a post-fixed chiasm with a tumor that is anterior to the chiasm, which is rare, or a purely third ventricular craniopharyngioma often mandates a different approach. In kids, the preferred approach in pediatric patients used to be an interhemispheric approach. And sometimes it is needed to do an interhemispheric, but we try to avoid interhemispheric surgery for craniopharyngioma because it almost always mandates traversing the hypothalamus. And especially in kids, we try to avoid any damage to the hypothalamus. So in a tumor like this, a combined approach may be needed, but our preferred approach is almost always from below. Another great approach, especially for purely third ventricular lesions, is a translamina terminalis approach. And I use this rarely, but it's a beautiful, very elegant approach for tumors that are located in the anterior third ventricle. So this was a lesion that's not a craniopharyngioma. This actually, I thought this was going to be a papillary craniopharyngioma. The woman presented with headaches, but on further inspection on imaging, this ended up being a cavernous malformation. But it's situated right in the anterior third ventricle. And although you could use an extended endoscopic approach for this, the chiasm is pretty much right in the way for this. So we decided to do a supraorbital craniotomy, and that was a perfect approach for this. So we do a small 3 by 2 centimeter craniotomy. We usually use an eyebrow incision, but in a young woman, this was a young woman who's around 30 years old, we don't like doing the eyebrow surgery for cosmetic reasons. So we do a hairline incision with a small supraorbital craniotomy on the right side. We do a temporary retraction on the gyrus rectus. Here's the right optic nerve, left optic nerve, and chiasm. And then as we retract and go farther back, we identify the optic tracts and lamina terminalis. We open the lamina terminalis, and then very careful dissection to identify the cavernous malformation. We, of course, suction out the blood contents from it and then work extracapsular to find the planes around it, and then detach it from its origin. And then we'll put an endoscope in to make sure that we've removed the entire lesion, which we did here. And MRI shows gross total resection, no vision changes, and no hypopituitarism on this patient. She did great. In terms of surgery for craniopharyngioma, when I was starting my practice, a lesion like this, I would do a craniotomy for, because I was still developing a learning curve for extended procedures. Now I would do this with an endonasal approach without any question. But back then, it's still viable to do a craniotomy for this. And so very similar, we would start with a craniotomy, do our dural opening, but then you reach a point where you cannot see superiorly into the third ventricle or hypothalamus. And so it's still possible to use an angled endoscope with a supraorbital approach. And this is something that people like Charlie Teo have really developed. But we'll start with regular tumor resection. And then once we've reached our limit, we'll use an angled endoscope and remove additional tumor here. And so this is also a viable approach, although, as I mentioned, I do almost all of my cases of craniopharyngiomas through the nose now, unless it's a reoperation or there's a lot of extension. So why is that? It's pretty obvious, but most craniopharyngiomas are at least partially cystic, and the long axis is directly in line with an endonasal approach. So these tumors really lend themselves to endonasal approaches, and most are retrochiasmatic, which is another reason. So here are some early cases. This is when I was working with Dr. Ed Laws in Boston. And these are some of the earlier cases where we would do a limited transtuberculum approach, open the cyst, and then work around it. And you get these beautiful views afterwards that I'm sure you've seen of the mammillary bodies, floor of the third ventricle, basilar apex, PCAs, PCOM arteries, third nerves, etc. And this is a view that you do not get almost anywhere else in neurosurgery, especially with a microscope. This patient had some hydrocephalus, so we did a reverse ETV, reverse endoscopic third ventriculostomy through the floor as well. So getting on to more difficult craniopharyngiomas, here's a transtuberculum approach. We then open the dura of the suprasellar cistern. We cauterize the superior intercavernous sinus. We then work inside the cyst to suction out some of the contents and make it lax. And then we work around it to detach it from the chiasm, PCAs, carotids. And then we have to make a decision. Can you preserve the pituitary stalk or not? In cases like this, where the entire gland is essentially replaced by tumor, we make a deliberate choice to resect the whole tumor and stalk, even if it will cause panhypopituitarism. This obviously can result in a cure and is preferred for these cases because hypopituitarism can be managed. I use a variety of repairs. I used to use fascia lata. Now I use more synthetics to avoid an incision in the leg, but routinely, of course, a pedicled nasal septal flap. And I will still use a lumbar drain for 48 hours at low drainage of about 5 to 10 cc's an hour based on their body habitus. Here's another case of a multi-lobed craniopharyngioma. Similar technique. This is a perfect one for endonasal approach. We're now removing the tuberculum sella. On this one, you do not need a transplanum approach. We use the Doppler. We cauterize the superior intercavernous sinus with bipolar cautery. We open it sharply. We then do a French door opening of the suprasellar dura. We open the arachnoid. We debulk the tumor, and then we use sharp microdissection around the tumor. We dissect it away laterally, as I mentioned, from the PCOMs and carotids and third nerves, superiorly from the optic chiasm, and posteriorly, of course, is very important because you have to dissect it away from not just the mammillary bodies, but the basilar apex. And on the basilar apex is where you have the thalamoperforating arteries. And that's where it's absolutely critical to use good surgical technique, is on the thalamoperforating arteries. Here's a synthetic graft using some alloderm. And then in this case, we used a gasket seal reconstruction as described by Schwartz and Anand. And you can see a complete resection. I only use a gasket seal graft if the carotid arteries are not fully exposed. If the carotid arteries are fully exposed, I do not like to put a plate in because I have had an issue with that in the past. So let's go on to even more challenging craniopharyngiomas. So this is a much larger one, as you can see here. And even this can be approached through the nose using a similar technique. In this case, there's retrocellar extension. So it's important to do not just a large transtuberculum transplanum approach, but we could, in this case, we know we will remove the pituitary gland, and we'll have to remove some of the dorsum sella to access the upper brainstem area. So again, we're doing here's our transtuberculum approach, opening the suprasellar dura, cauterizing the sinus, opening the arachnoid. We'll start with some debulking always, just to reduce the size of it and be able to fold it in. And here's the normal gland that we've decided to sacrifice in this case. We're now using a 30-degree endoscope to dissect it from the chiasm. And now we've done our bony removal of the sella, and here's the basilar apex. So very important structures here, PCA, P1, SCAs, third nerves, but it's really the thalamoperforating arteries that are very important to preserve here as you peel off the back capsule and start to work up towards the mammillary bodies. So I'll just let this play. And you want to just take your time with fine micro dissection here. It's sometimes the lateral walls that are challenging here, and then working superiorly to dissect it away from the third ventricle and chiasm. And once you've done that and detached it circumferentially, the whole tumor can be removed en bloc. And then, of course, inspection, in this case, confirms a full resection. When there is a lot of dead space, that's where I really like to use fat. And then we will usually do a fasciolata closure in these larger cases. And in this case, we did not use a gasket seal, just a flap to cover it. And you can see the resection there with the flap. In complete resections, we do not do radiation. We will observe the patient for recurrence. But if there is residual, then we will, of course, use some type of radiation, whether it's IMRT or stereotactic radiosurgery to target the residual. Or, of course, at first sign of recurrence is when we will employ radiation. So there is pretty good data for management of residual recurrent craniopharyngiomas. And we know that radiation helps, but the best thing you can do is completely remove the tumor because leaving any behind is a major risk factor, of course, for recurrence. There are some earlier reports of Gamma knife as well, which is pretty good at tumor control. But really the most important thing in the last decade that has emerged, of course, is the genomics of craniopharyngiomas. And this is really has the promise to revolutionize skull-based surgery. Of course, the first one was in papillary craniopharyngioma, where BRAF7 mutations were detected and can be treated now with BRAF7 inhibitors. And of course, we've now in adamantinomatous craniopharyngiomas discovered the CTNNB1 mutation, although there have not been treatments for this that have been targeted just yet. So I think this is the future of craniopharyngioma therapy. There will still be a role for surgery, but we may find that there may be even a role for neoadjuvant treatment, meaning treating upfront with medical agents to try to shrink the tumor and then considering surgery and saving radiation maybe for the very end. So this is a very, very important paradigm shift in skull-based tumor management. So those are my thoughts regarding Rathke's cleft cysts, cystic sellar lesions, cystic adenomas, and craniopharyngiomas. I hope I've been able to share with you that we should maintain a broad differential diagnosis and just some of the treatment pearls that we consider here in our practice at the University of Southern California. I want to really thank everyone at the İzmir neuroscience program, and in particular, Professor Hassan Suçu for the invitation to speak today, and to thank you all for your attention. And I'd love to answer any questions and engage in any type of discussion regarding this. So again, thank you so much. I'm very honored to be with you all today.
Thank you, sir. Before I forward you to questions, okay, you stopped screen sharing. I'm starting with Dr. Selim Bozdağ. She's one of the graduates from our hospital, our clinic. She is in customer training and research hospital right now. Thank you very much for your presentation, full of great case examples. When you open the cyst to the arachnoid, do you take extra precautions to prevent post-op CSF leakage?
It's a good question. I would ask Professor Bozdağ, is this for arachnoid cysts or Rathke's cleft cysts? For arachnoid cysts, we do not, although some people have discussed using lumbar drains for these, etc., and packing. But no, we do not up front. If there's dead space, we'll use some type of packing, but we don't use anything else up front, such as a lumbar drain, unless we know it's an extended approach. But some people like using lumbar drains for all of these up front to reduce the cyst pressure up front. But we do not do that. It's a great question.
Associate Professor Ayhan Kanat, thanks to you for the good presentation. Nurul Huda Maria, very nice lecture indeed. Thanks a lot.
Thank you.
Ayhan Kanat adds anecdote, historical, in the history of Rathke Cleft Cysts procedure. Can the surgery of Finus Clara Haskell in 1942 be the first case? Yes, and adds in 1942, when Clara Haskell was 47 years old, she displayed the first symptoms of suprasellar brain tumor, headache, and hemianopsia. The famous surgeon Marcel David performed surgery on her without general anesthesia while Haskell mental played Mozart Piano Concerto as a neuronal representation to control her memory and mental abilities. Only 3 months after that operation, she played Mozart's Piano Concerto and at a concert that began her career as a great interpreter of Mozart. We had written the surgery of Haskell and its links.
Yeah, this is amazing. I am not aware of this case until now, and I will look at this in more detail. But thank you for sharing this with me. I have not heard of this report of awake craniotomy in 1942, but very interesting, and I need to learn more about it. I'm very curious about it. So thank you for writing that up and sharing it, and I will definitely look at it.
Thank you, sir. Dr. Alaaddin Bayrak, thank you very much for excellent presentation. And Professor Dr. Bektaş Açıkgöz, thank you very much, Professor, both for your excellent work and sharing your experience with us. I also thanks Professor Suju and team for the excellent meeting. Do you have experience for spontaneous disappearance of RCC?
It's a great question. I have seen shrinkage, but never full disappearance on a few cases, especially if there's occasionally you see hemorrhage into a Rathke's cleft cyst. And we published a series last year of hemorrhagic Rathke's cleft cysts that mimic pituitary apoplexy. So sometimes they can present acutely with a severe headache, and one of the hallmarks is hyponatremia that they can present with. And so we had several patients, and I've seen it shrink with the natural history, but never have I seen complete disappearance, although I know it has been reported. And of course, there's also reports of Rathke's cleft cysts transitioning and becoming more aggressive into craniopharyngioma as well. It's a very good question.
Thank you, sir. Nuri Erap Çetiner from Çukurova University. Do you have a limitation in lateral extension of the tumor while designing for the endoscopic approach?
Yes, it's a good question. It depends if you mean along the skull base or intracranial. If it's along the skull base, we can go very lateral now, as you know, with transmaxillary, transpterygoid approaches. So even to the middle fossa floor, Meckel's cave, we can go to. Intracranially, it's usually the medial Sylvian fissure is where I will consider my limitation. If the tumor extends into the Sylvian fissure or beyond the bifurcation of the carotid, I usually consider that a limitation. Although you're right, if you can debulk or have the cyst shrink, sometimes you can remove a cystic component that goes very lateral. But solid tumor that's adherent to the carotid or MCAs, I think is very challenging, even with angled lenses. Sometimes you can see it, but to turn the corner around the carotid and carefully dissect it is very difficult. We don't have the instruments for it yet to do fine-handed microdissection around the corner. And that, for me, that is the lateral limit currently.
Thank you, sir. And I think there's no question. And Kamil abi.
Okay, I want to thank Professor Gabriel Zada for this excellent lecture. Especially his videos drove us into the surgery and made us feel like we were doing the surgery ourselves. And there are not only Turkish neurosurgeons among us, we also have a colleague from Pakistan, Nurul Huda Maria. I am also curious about her thoughts. Atacan, please can we turn on her microphone? And
Bu hocam anlamadım.
Nurul Huda Maria.
Nurul Huda.
It's okay.
Okay,
Okay.
you can turn on your microphone.
Thank you so much. Thank you so much, sir. It's a huge honor for me to be here. Thank you so much for providing me this privilege, and thanks a lot, sir, Professor Gabriel Zada, for your extremely informative and incredible lecture. That's a huge, it's a huge thing for us, especially the young neurosurgeons who are still in the learning curve and just get to know such wonderful cases. So it was an incredible experience. Thank you so much to all the organizers for the wonderful lecture and for the wonderful webinar.
Thank you so much. Thank you for your comments.
Thank you, Maria. And I think all the questions and comments is over. I want to thank again to Professor Gabriel Zada for accepting our offer to speak. It was a great honor for us to have Professor Gabriel Zada as a lecturer today. Thank you.
Thank you, everyone. Thank you, Professor Suchu. I appreciate the invitation.
Thank you. I hope we see each other face to face in a short future.
I would like that too. I hope we can. Hopefully the COVID goes away for good and we can all meet again. I would like that.
Thank you.
Thank you.
Thank you, everyone, to join us today.
Thank you.
Ajan, we can stop the